Good evening to everyone and welcome to today's session. We are starting the second most important subject, ophthalmology. Ophthalmology basically has got around 30 important topics and another 30 very minor topics. Actually, we plan to finish it in 5 days. Maybe we may take 2 more days extra. Totally about 7 days we may take, and we will end up in giving you nearly around 150 pages of study material to revise this important points in all the 60 topics. So our first topic is in fact the largest topic, glaucoma. So today it is all about the glaucoma. We invite our online students, Dr. Neena, Amrita, Kavya, and the students from Raipur, Dr. Renuka, Kavita, Tirupati, Guntur, etc., etc., and our stalwarts of the Usmania Medical College who are going to top the next entrance, positively be the NEET PG of November 2013. So let's make the start. Intraocular pressure is the most common risk factor for the development of the glaucoma, as all of you know. Now, few definitions you need to be very, very clear with, doctor. Please let me know if the voice is loud and clear or not for everybody. Otherwise, we will make corrections. Now, ocular hypertension, when do you call it as? If there is a raised IOP without any glaucomatous changes, if you examine the fundus, you call it as simple ocular hypertension. It is called normal or a low tension glaucoma if there is cupping of the disc or the visual field defects in spite of a normal or a low intraocular pressure, then you call it as normal or low tension glaucoma is what you have to basically remember. Now, what is the general classification of the glaucoma? It can be congenital or developmental glaucoma, which can be primary congenital, or it can be associated with some anomalies, then you call it as developmental glaucoma. Then you have primary adult glaucomas, which can be a primary open angle, primary angle closure, or a primary mixed mechanism. Then you have secondary glaucomas. Then what is the main reason that glaucoma should lead to the development of the vision loss and the ocular damage? Typically, whenever there is a rise of the intraocular pressure, progressively there is a compression on the optic nerve, and that leads to development of optic nerve atrophy, which is the main underlying cause for the development of the visual loss in case of the glaucoma. Now in the retina, which is that very sensitive cell which get affected, doctor? Typically it is the retinal ganglion cells which are the ones which typically die in case of the glaucomatous damage. Ultimately there is also a damage due to the compression. There is a hypoxic injury to the retinal nerve fibers also. Now doctor, what are the main etiological factors in general, not specifically but in general, for the development of the glaucoma? One theory is mechanical theory, that there is a raised intraocular pressure which will stretch the lamina cribrosa. This is one of the favorite MCQs in the AIMS question bank. Stretching of the lamina cribrosa is one of the important underlying cause for the development of the optic nerve damage in the case of the glaucoma. Similarly, there will be axonal deformation, ischemia, and because of that high mechanical pressure, the neurotrophins, which are the growth factors, are unable to reach the retinal ganglion cells, which are all implicated to be the underlying causes of glaucoma. There is another theory which says it is the vascular insufficiency which leads to the development of the glaucomatous damage. So why did we basically got a thought that possibly vascular mechanism is responsible. Because if you look at the glaucoma, it is found to have an association with some vasospastic disorders, especially with the migraine and Raynaud's phenomena. They are typically associated with the development of glaucoma. There is one more theory which said, suppose if somebody is receiving antihypertensives regularly, in the night times there is a sudden drop of their blood pressure which leads to the development of the ischemic damage. So there is a reason systemic hypotension is also considered to be one of the important implicated causes for the damage. There is a theory of excitotoxicity where the glutamate is the major excitotoxin which is implicated in the glaucomatous injury to the nerve cage. So that is all about glaucoma. What are the various mechanisms? Now let us take up the first important class of glaucoma, which is congenital glaucoma and a primary developmental glaucoma. When do you call a congenital or a primary developmental glaucoma? There should not be any anomaly in the eye. So without any ocular or a systemic anomaly, if there is a very high intraocular pressure, then you basically call it as the congenital glaucoma. So what is the reason that a newborn baby is born with congenital glaucoma? One theory says it is during the intrauterine life it is responsible. And whenever in the intrauterine life, constantly when there is a high pressure, by the time the baby is born itself, he has got an ocular enlargement. Then you basically call it as true congenital glaucoma. Then you have infantile glaucoma, where the glaucoma will typically manifest before the child's third birthday. This word third is very, very important MCQ in the exam. Is it the first year only infantile glaucoma is seen or second year infantile? The word infant is confusing here. So it is infantile glaucoma, it can appear until third birthday. The word third is most important. Out of all, it is the most common type of congenital glaucoma, infantile glaucoma. And you know that because of the glaucoma, the eyeball will enlarge and it will look like the eye of a bull, which is called as the ophthalmos classically. And over a period of time, it leads to the retention of the aqueous humor, and hence it is called hydrophthalmos at a later point of time. So these are the typical bulls-like eyes which you see in the case of the ophthalmos is what you need to remember. Then you have, after infantile glaucoma, a juvenile glaucoma. Once more, age is very important MCQ in the exam. Between 3 to 16 years of life, the development of a glaucoma due to a congenital problem is basically called juvenile glaucoma. Now, typically the disease is bilateral and about 65% of them are boys. Because of this, it is thought that there is a genetic predisposition for the development of congenital glaucoma. Now, what are the main factors responsible for the pathogenesis of the congenital glaucoma, doctor? You know that there is a trabecular meshwork which is helping the drainage of the aqueous humor. It is the dysgenesis of the trabecular meshwork is one of the important theories responsible for the congenital glaucoma, and a flat insertion of the iris. Because of the flat insertion of iris also, drainage becomes a difficulty. Now doctor, what are the cardinal clinical presenting features of congenital glaucoma? One of the favorite questions of the examiner. Photophobia, blepharospasm, lacrimation, and the rubbing of the eye. In this, photophobia is the buzzword. You should not forget, one of the common questions asked in the entrance. Photophobia, blepharospasm, lacrimation and eye rubbing They are the ones who chucker together and mainly responsible. Then are there any corneal signs in the case of the congenital glaucoma, doctor? Corneal edema is a very important feature because the raised intraocular pressure, there is a development of the corneal edema which will make the cornea to become hazy in case of congenital glaucoma. Now enlargement of the cornea is the third important clinical feature in congenital glaucoma. Obviously the question comes, what is the normal corneal diameter? Enlargement of how much is called as congenital glaucoma? Favorite MCQ of the examiner. Normal infant cornea measures around 10.5 millimeters. Any corneal diameter more than 13 is the golden number which you should not basically forget. So ultimately when you go for the entrance exam, there are 1200 topics at most, and on each topic there are not more than 20 points. Totally 25,000 points database you must know. That is called as winning entrance exam. In those 25,000, 1/4 of 1 lakh, 25,000 points may, there will be some 70%. How much is 70% of 25,000? Nearly about 14 to 15,000 points. एक बार सुने तो जिंदगी में कभी भी नहीं भूल जाओगे, kind of points. But there are 10% in this 25,000 which are nearly about 2,500 to 3,000 points. You need to revise. This kind of stupid numericals like 13 mm, 10 mm, 10.5 mm, you should not do mistakes in the exam. So you are not going to forget 13 mm is the buzzword. If at all this diameter goes to more than 16 millimeters, prognosis of the congenital glaucoma become worse. Now what is a very important hallmark of the congenital glaucoma, doctor? Tears and breaks in the Descemet's membrane. What are they called as? Half striae is what you should remember, the buzzword. Half striae are what you classically see in the case of the congenital glaucoma. Where are these tears located? In the periphery. Concentric with the limbus is what you have to fundamentally understand. So doctor, these are the half striae. The breakages because of the raised intraocular pressure, the breakages in the Descemet's membrane of the cornea are called as half striae. Ultimately the sclera become thin. It typically becomes blue because of the underlying uveal tissue. A thin sclera is that white part. When it becomes very thin, underlying uveal tissue will be seen and it looks like blue sclerae. Then how is the anterior chamber? Generally we expect anterior chamber to be shallow. If it is, most of the times in glaucoma, that is our expectation, normal or shallow. But how is the anterior chamber in case of the congenital glaucoma? Favorite question of the examiner. It is deep anterior chamber is what you need to remember. Then the iris typically will become atrophic. Initially iridodonosis is what you see. Then the lens become flat because the stretching of the zonules by the raised intraocular pressure, and ultimately it may even subluxate. This another important MCQ in the exam. Flattening of the lens. Where do you see? What is your bold answer? Congenital glaucoma is what you need to remember. The optic disc will show cupping like any other glaucoma. And if you look at the intraocular pressure, the IOP is raised. But unlike the closed angle glaucoma, etc., it is not a marked rising. It is not an acute rising in case of the congenital glaucoma. And ultimately because the axial length of the globe increases because of the stretching of the cornea in case of the glaucoma, any increased diameter of the cornea globe leads to myopia. So there can be development of axial myopia, and that can give rise to, because when is this happening? Basically, infantile glaucoma can occur up to 3 years, juvenile glaucoma between 3 to 16 years. So because of this, what will they develop? Anisometric amblyopia can develop as a complication. So that is the reason any refractive error in a pediatric population, you need to act emergently, otherwise it will lead to amblyopias. So that is the reason stretching of the globe leads to axial myopia. Axial myopia predisposes to anisometric amblyopia. That's what you need to ultimately remember. Now, what is the differential diagnosis for the ophthalmos? Any raised IOP in an infant. The beautiness of MD entrance preparation is, until we read ENT, we should feel we are the best otolaryngological surgeon. Today morning we did tonsillectomy, tomorrow morning we are going to do cochlear implant. That feeling you must feel. Other day evening we have done canal wall up and down mastectomy. Once more, when you go to ophthalmology, you need to switch over your position to think the way ophthalmologists think, sitting in an OPD. Then you will enjoy the subject. Even your hospital posting is, in housemanship you have 2 weeks of ophthalmology, no? Before that only you are finishing. So when you go the 2 weeks of ophthalmology posting, you try to enjoy more. Try to see more eyes, more ophthalmos, more half striae. Then you can club both your preparation for MD entrance and housemanship posting, safely rowing together. And let me tell you, other than reading these 1200 topics, 25,000 points, there is no need of bothering about anything. You trust me, you follow me, you read before coming to class and review after leaving home and see the patients. Comfortably you will get seat in the top 100. Let me very clearly tell you. I take 10 hours of time before deciding on one simple issue. What is that? Which points I remove from the notes, which are definitely not required for entrance even in the remotest scenario, and incorporate only the points which are frequently asked. So there is a whole deal between both of us. So doctor, a raised IOP is a feature in retinoblastoma, retinopathy of prematurity, and Stooge-Weber syndrome like scenario also. Now doctor, out of all these, 2 differential diagnoses of ophthalmos are frequently asked in exam. One is megalocornea. When do you call megalocornea? Normally horizontal diameter at birth is 10 mm. Adult size is 11.7 mm, which is achieved by 2 years of age. Megalocornea is labeled when the horizontal diameter is at birth is of adult size, or if it is more than 13 mm after the age of 2 years, then you basically call it as megalocornea. The other condition is keratoglobus, not conus. There is a thinning of the cornea in this, along with a hemispherical protrusion of the entire cornea, but it is a non-progressive condition. You have it forever, kind of a entity. And the cornea, it typically seems enlarged, but the diameter, if you take, it is not increased. So that is another important. It is a problem with the shape, not with the size, in the case of the keratoglobus. So doctor, this is one table you need to fundamentally master. Yeah, Sarvodaya is saying at least try to upload the video notes 2 hours before the class. It's a good point, but the problem is Yesterday, day before yesterday, I was in Tirupati and Kadapa. Kadapa, we had about some 300 students whom we addressed, who are in second year, third year, etc. So, today morning after landing in the airport, everywhere I was preparing notes only. So, I could not get time, but tomorrow onwards we will try to do that a little more earlier. Huh? Alright. In ENT, there are few more topics, small minor topics like laryngomalacia which are left. I will take one more day to revise that. I will take some time in the middle, but let us start ophthalmology, I thought. Okay. Megalocornea is typically autosomal dominant, and you have infantile glaucoma and ophthalmos, it is sporadic. Forget about this middle one, I am talking about the first and the third one. Bilaterality is a typical feature of a megalocornea, but ophthalmos can be unilateral or bilateral. Then if you look at the symmetrical nature, it is symmetrical megalocornea, but that is typically asymmetrical, ophthalmos. Similarly, corneal clarity, if you look, you have a clear cornea. This is one favorite question. Megalocornea never will have a hazy cornea. Why? Because there is no corneal edema or there is no raised intraocular pressure. Whereas in the case of the ophthalmos, what you have is a diffuse hazy edema with the tears in the Descemet's membrane because the raised intraocular pressure. Then keratometry, if you do, typically it is a normal thickness in case of the simple megalocornea, but in case of the infantile glaucoma, typically it becomes thicker. And in the case of the keratoglobus, it becomes typically thinner. So this is how we differentiate between all this. Now, how do you want to treat the congenital glaucoma? Very good. Today we have some new friends, Dr. Richa and Dr. Suren. It is mainly surgical to treat. We give hyperosmotic agents, acetazolamide, beta blockers until the surgery is taken up. See, if you look at the various glaucoma drugs, what is the missing glaucoma drug in this? Pilocarpine is not there. So, miotics have no role in the management of the ophthalmos. This is another favorite MCQ of the examiner. Fundamentally, we have two groups of drugs. One which will increase the aqueous outflow, other which will decrease the production. So, we must know which drug to use in which scenario. Now, what are the surgical procedures for the congenital glaucoma? We can do goniotomy, trabeculotomy. Trabeculotomy is typically done if there is any corneal clouding and you are unable to identify where is the angle of SLEM and you can't do goniotomy, then you will be doing trabeculotomy. And always the main difficulty in the glaucoma surgery in congenital glaucoma is where is the Schlem's canal. To identify that is the whole challenge. And nowadays we are doing both tomy and ectomy. Trabeculotomy and trabeculectomy is the present preferred surgery of choice. Favorite MCQ of the examiner about congenital glaucoma. So doctor, this is the cornea. You are using a trabeculotome to open up the trabecular meshwork in the case of the congenital glaucoma. This is the goniotomy. If you are able to get the angle, if corneal edema is not significant, then you can use the goniotomy. Now doctor, this is the entire story on ophthalmos. What are the various developmental glaucomas which have a associated anomaly? Our ophthalmos don't have any associated anomaly. There is a glaucoma with a iridocorneal dysgenesis, glaucoma with axon fields anomaly, glaucoma with Rigger's anomaly, Peters anomaly. But what is important for the entrance is axon fields anomaly. Just you need to know what it is. Everything is imagination only. because until you become an ophthalmic surgeon. So doctor, Axon Fields anomaly is also called posterior embryotoxin, where Schwalbe's line is anteriorly displaced and associated with the iris bands, and if it is also associated with pupillary abnormality, then you call it as Rigger's anomaly. You can forget it. Just for the sake of knowing, you need to remember. Otherwise, most important topic is congenital glaucoma. That you already understood thoroughly, and what are the critical points you understood. So, there can be few congenital glaucomas because of the ectopia lentis, because of the displacement of the lens. What are they? Marfan syndrome, Weil-Merkensenis syndrome, and homocystinuria. There is a glaucoma along with lenticular dislocation. Then what are the glaucomas associated with phacomatous neurocutaneous syndromes? Sturge-Weber, von Recklinghausen, and Lois syndrome. What is Lois? We studied in nephrology. It is an oculocerebrorenal syndrome where you find abnormality in all these structures. Lois syndrome. So that's all the story, doctor. By now you must be quite sleepy. We'll taste few questions in glaucoma from the All India AIMS PGI question bank. Then once more life looks interesting, why we are reading. Purpose will be discovered, right?